Welcome to part two of the Doctors of Courage podcast interview with Dr. Neil Anand. Dr. Anand is a board certified anesthesiologist who was attacked by the government in September of 2019. And since that time, the government, being that he hasn't been able to go to trial because of COVID and other things that, of course, extend everything, as for most of us it does. But he's been a fantastic researcher, and he has learned so much and contributed so much to Doctors of Courage knowledge base and to every other doctor that's been attacked as to how the government is doing what they're doing. So in this particular part two, we want Neil to actually go through some of the information that he has gathered on how the government is targeting physicians. I will say before we start, Neil, if you don't mind, back in 2006, when I was first attacked, my impression and what I've carried to this day is that the government is attacking independent physicians that are minority and that are treating the patients that I consider to be expendable, which there are 5 categories of patients that are expendable, and they are government insured, the poor, the disabled, and the elderly, and the uninsured. Although nowadays with after President Obama, we shouldn't have that many uninsured. But the expendable patients are basically people who are not contributing to our tax revenues anymore. And the government wants people to only be contributors. They do not want people that actually take away from our coffers, but put money into our coffers. And so I really do believe that we are in a case of legal genocide in this country to eliminate those people. And then, but in order to do that, they've made a kind of a collusion with hospitals so that the independent physicians, which are working for patients, they're not working for hospitals, that the independent physicians are then taken out and attacked. And this is just one method that they're able to do that. Now, after Ruan and Khan, which is for people listening to this broadcast maybe for the first time, Ruan and Khan were Supreme Court cases that came into the Supreme Court last year and were announced in June of last year, that says that a doctor has to have basically mens rea, which means that they have to have a idea of that they are committing a crime for them to be criminally prosecuted for that. So even though they are still attacking doctors for treating pain, what they're doing now, if you notice, is moving more away from the pain management alone and incorporating now healthcare fraud, because healthcare fraud is a much harder. There is no Supreme Court decision saying the doctor has to be aware that they're committing healthcare fraud for it to be a crime. They can charge people and commit people for healthcare fraud just based on the propaganda that they have out there that doctors are all in it for the money. So anyway, Neil, I'd like for you, if you would, to begin to just wherever it is you want to start, if you'd like to start to show people the data that you have, and also any kind of conclusions that you might have for why and how they target physicians.
Okay, so I'd like to start here with the Doctors of Courage, webpage, which is a great resource, I think, for physicians throughout the country. You have now, it's just terrifying, and just to see this picture here that you have up front of all the faces of physicians here that have been attacked. I mean, it's just an extremely powerful image. It always, shocks me. And this is just a very small number. I mean, if you start going down the page, and you can see here on the eastern half of the country, if you see here what has really happened and the location of where the professionals are attacked, it looks like everything east of the Mississippi River it's a catastrophe for physicians. You work east of the Mississippi River, you're going to get attacked as a physician. Less so, west of the Mississippi River. But anyway, if you start scrolling down, I mean, it is just a nightmare. I mean, I'm just slow scrolling through the number of physicians, and this is not even a complete list. I mean, if you want to get a complete list of physicians attacked, we have to go to the National Practitioner Data Bank, and we have to go to the OIG exclusion list. Once you start combining the National Practitioner Data Bank with the OIG exclusion list, we'll get a complete picture. We've asked the United States government, hey, give us all this information. They obviously don't want to give us all this information because it's a real problem. It might even expose real corruption within our government that are hiding this, persecution of American physicians.
Yeah, most of the doctors that are on this list are doctors that I have came across basically from media reports. I had a Google search for doctors attacked for pain management. And so anytime a doctor would be attacked and it would be printed in the media, I would get notified. So I kept this list. The problem is today, see this back 10 years ago, 15 years ago, anytime a doctor got attacked, it was immediately news. And the media would jump on it and they'd write up an article about this, bad doctor or whatever doing this. And so you'd get these media reports, but now it's not news anymore. There's been so many attacks on so many doctors that they don't even report it, put it in the newspapers anymore if a doctor's attacked in that area. So I've kind of lost my ability to actually, find the doctors, and so we have like you say, there's a lot more out there that have been attacked than what my list shows.
Right, and
but I do have a list right now of over 2,100 doctors that have been attacked. Or when I say doctors, excuse me for all the nurse practitioners out there who are also, if you're a medical professional, if you've worked in an office, even if you're an employee of an office and you've been attacked, you're on the list. And so it basically involves anyone that's been attacked by because of treating pain.
right. So that's a really great overview. Thank you so much. And I'm going to show you some of our databases that we have at Doctors of Courage, where we've gone through and looked at the different healthcare fraud strike forces, that predominantly arrest physicians. We've looked into physician arrests by state, we can see here Florida is the highest, followed by Pennsylvania, then New York, then California. Basically, wherever there's a healthcare fraud task force, you're at risk of being arrested. Not only have we looked at different states, I mean, you can see wherever there's a a prescription drug monitoring program. Any state that has a prescription drug monitoring program, the number of arrests keep going up because they're using prescription drug monitoring program data to target and attack physicians. But
even though, if to clarify it for people listening, even though when the prescription drug monitoring program was created, the only people who were able to access that were the doctor of the patient and the pharmacist of the patient. Law enforcement was not allowed to get into that because it was considered to be private information. And then somewhere along the line, suddenly, all of a sudden, law enforcement had access to the patient monitoring or drug monitoring programs. Do you have any insight into how that happened, Neil?
Yeah, I have some insight, and we'll go over that data. I have a PowerPoint. We'll go through that hopefully at this session, or maybe even next session. We can break this apart into two parts and go over the data, because we've collected this data over a period of years, right, Dr. Cheek? And nobody's really gone over that data. We have never gone over it in YouTube or a podcast video before, and I think now is the proper time to go over all of this robust data that we've been collecting over years and years and years. So
okay, Neil, you keep talking for just a minute. I just found out that oh wait, maybe it's here. Go ahead. Somehow or other, I did not plug in my computer, so it's saying battery is running low. Let me do that. But if you go ahead and I'll make sure I get it. Okay, I'm on.
So basically, we look at the data here. We break down the data that you collected, and then I collected, and some other doctors around the country have collected, and we broke down the data into their race of the physician, the gender of the physician, the year they were born, or the year they were arrested, and what sentence they got or sentence they pleaded to, And then over years, we collected the names, and then we discussed, through different iterations over time, over a period of years, we got a more complete picture of not only, and then we started even breaking it down into religion to see if certain groups of people are being attacked, and is this legal and constitutional, or are there constitutional violations with suspect class members, essentially different genders being attacked, different races being attacked, different ages being attacked, different practice types being attacked. And I'm going to go over the data, but we basically broke this down. We even got the data from the Drug Enforcement Agency, which is it's not robust at all. I mean, they have very minor studies, but we looked into from the Drug Enforcement Agency, what type of physicians are being attacked, in the United States, what percentage of physicians, what practice type of physicians. And we learned that, very early on, that the Drug Enforcement Agency is not really collecting this kind of information, hasn't really analyzed this information as well as we have at Doctors of Courage and other organizations. And we have all this data, which we are willing to share with other organizations and collaborate, right, Dr. Cheek,
Right.
to solve these problems. So we've collected a whole bunch of graphs, what's actually happening in terms of opiate, what's actually happening in terms of suspension orders, and what's actually happening in the United States to cause more and more deaths. More and more people are dying, even though there's more action by our law enforcement and drug enforcement agency. More patients are dying, and one of the reasons we think that most patients are dying is for a patient who seeks a physician who's accredited by the state, has gone through residency, gone through medical school here. That patient will benefit from having a physician. And that benefit is greater than the risk of not having a physician. Plus, a doctor is prescribing a medication that the FDA has approved, and the FDA has said that drug is approved because the benefits are greater than the risks. So now, by taking out the doctor and taking out the medications, you're just increasing risk. Now the patient has no doctor, where the benefits are greater than risks, and the patient's not even getting a medication anymore that's FDA approved, where the medication benefits are greater than risks. So all we have is risks, all we have is problems. And I'm scrolling through this right now, and we're seeing even a lot of Jewish physicians are being attacked for being Jewish, or independent practitioners, and it's causing a crisis. And I'm going to show you the actual data now. Here, let's see if I can bring that up.
One thing I've noticed while you're doing that, is that a lot of the big hospitals, especially hospitals in New York, SUNY is a big one, and many of the others, they bring in, for the most part, a higher majority of immigrant. They're not even immigrant. They're actually, people. They haven't become Americans. They're actually people who lived in other countries, and they're brought into their residency programs and their medical school programs. But then as soon as they stay in America and go out and create jobs and create businesses in America, they get attacked and then thrown into a prison. Basically, it's slave labor. In my opinion, they've turned the medical profession into a profession of slave labor, because these doctors don't get paid anything during medical school when they're working in hospitals. They don't get paid hardly anything when they're residents, and so they use them as slave labor in these hospitals, and then turn them into slave laborers in prison camps later. That's the way I see it being done. And they have just totally destroyed the medical profession. It's not a safe profession anymore for anyone to get into.
Yeah, it's definitely a 13th Amendment violation. I agree with you wholeheartedly. By talking with so many physicians around the country, it's become a slave mentality here. I mean, you do not see the insurance companies. They don't go after the insurance companies and arrest all these insurance companies. Throw the insurance agents in prison or whatnot. It's just a one-sided war against a medical practice, and frankly, a lot of physicians have had enough of it and are abandoning the practice of medicine wholesale, and it's disgusting. Frankly, it nauseates me. Even
Mhm.
this, if you see this, you can see, blacks make 3 to 5% of physicians, and based on our preliminary analysis of our data, which is extremely robust, it's been checked a few times. You can see there's a very high risk if you're a physician that's non-white of being attacked. And then by age, you can see here. I mean, if you add these three categories together, it's of 70%.
Right. If they have money that the government can confiscate and assets that the government can confiscate, they're going to be targeted.
Right. So above 50, above age 50, above age 50, you're 77%, have a 77% chance above age 50 of being criminally indicted by our government. It doesn't even make sense, and I'll tell you why. The reason it doesn't make sense is that um, an elderly physician or physician who's been practicing for a large number of years is more experienced. I mean,
Right.
we don't say experienced judges are criminals, or experienced bankers are criminals, or experienced football players are criminals. Also, younger physicians, they have a more incentive to earn money and create, because they have families or whatever, as compared to older physicians. So it doesn't even make sense that an older physician all of a sudden at an old age starts deciding, hey, let's become a criminal, let's defraud the government or start becoming a drug dealer. None of this makes sense when you look at just the data from a forest from the trees point of view. And you can even see that even being white, as you get older, I mean, the risk of practicing as a white physician also increases tremendously the older you get. And you and I have talked about that before, outside of this interview, and said that this is an asset confiscation scheme. And 72% of degrees are doctors. So we've broken this down by type of occupation. If you're a PhD, you're at low risk, but if you're a doctor, you're at high risk. Your race, your age, and we've categorized all this information. And once we categorize this information, we said, hey, statistically, this is a very strong sample. This is definitely less than a p-value of 0.05. So we have a strong statistical sample. Obviously, you have 2,100 patients. We only looked at 1,400 patients when we ran this analysis.
Doctors, not patients.
Yeah, doctors.
Yeah.
I'm sorry. Yeah, we looked at only 1,400 doctors that were attacked and tried to see what conclusions we could come up with. But it shows, yes, if you are a non-white physician, you have a higher risk. If you are an independent practitioner, you have extreme high risk. If you are above the age 50, you have extremely high risk of being attacked by the government. If you are in a certain practice location where these fraud task forces exist, you're going to get there. You have a high risk of being attacked. But if you're working for a hospital, it's a low risk. If you're working by yourself, it's extremely high risk. So
But is that really what doctors should do? Should all doctors just scurry to become hospital owned? My goal is to actually make hospital owning doctors illegal, that the law needs to change and doctors need to be independent, because to me, hospital owned physicians work for the hospital. They work to make the money. That's where most of the fraud is, in my opinion, because they're told to order all the tests they can order and do everything that they can do to bring in the money. And yet and then when a elderly patient comes into the emergency room, the doctors immediately try to put them in DNR status. I mean, to me, hospital-owned physicians is horrible, and I just would wish that could end.
I
What
mean,
do
I
you think?
have a different perspective. I mean,
Okay, go ahead.
my perspective is this. I mean, I was in the military, and the whole point was accomplishing the mission, and money be damned, the cost be damned, because if you want to accomplish the mission, all that matters is accomplishing the mission. Obviously, we can always print more money, or there's money problems, or they're important. But when you go into a hospital, it's important to order all the tests. It's important to do everything you can for that patient.
Well, my comment isn't in the hospital. It's the hospital-owned physician clinics. See, in our area, our big hospital in the area came around and scarfed up as many independent physicians as they could. And one of the doctors actually left the hospital because he said, well, what they're telling me to do is they want all the lab orders that I can order. They want every patient to go to physical therapy, the blah, blah, and all these conditions are hospital owned. And
Right.
so, they're making it's and not necessarily, I understand when you're in the hospital, you need the tests run, but I'm talking about the clinics that are just
Right.
running unnecessary tests because that's their job, to make money for the hospital.
Well, the way I'm a big free market guy, and my issue is the hospital can do whatever it would like within its, but there should be independent practitioners should be allowed to compete with the hospital.
Mhm.
And patients should be allowed to choose which doctors they I'm a big fan of competition. I think it's very important to have competition in a society and to allow for that competition. Well, the problem is that a lot of these hospitals have become extremely large. They're basically, large groups of hospitals that have become monopolies. And now you also have these insurance companies that have become extremely large. I mean, 6 or 7 insurance companies dominating the whole healthcare industry. And you have a war of the monopolies. Like, you have these large healthcare systems that have 20 hospitals in them, 30 hospitals in them. They own, 100 physician offices. And now you're trying to compete with them, and they say you're a bad physician and then take you out of the market. I mean,
Right.
they don't allow that in Google. Google can't do that. Go and say, oh, criminally indict, Facebook. It would be considered preposterous. So go arrest Twitter and Elon Musk so that he can't build his rockets. I mean, it's just preposterous. It's become a disaster. If you look at our medical field, we don't have an Elon Musk. We don't have a Steve Jobs. We don't have anything like that. Before you could name big physicians, Louis Pasteur, Jonas Salk. We talked about Ignaz Semmelweis. Dr. Norwood. There's so many famous physicians. They're gone. The most famous physician in the United States is Dr. Anthony Fauci. Well, Dr. Anthony Fauci is a government employee. And why is a government employee the most famous physician in America? It should be a physician innovator, and we've lost all that.
Right, exactly. Yeah. So, okay. So how did you, as far as the, can you go more into some detail now about how you went about gathering this information, what kinds of questioning you did for the government, and what kind of information you got back, and were they just, oh yes, we'd love to give you this information, Dr. Anand, or was there a little bit of fight to it?
Oh no, there's a big fight to all this cheek, and you know that because you've helped me, and other doctors have helped me. But basically, once we collected a lot of this data, it raised some questions on how does this actually system work? How are they actually targeting a physician? How did physicians that rarely were arrested and gone to prison, how did this mass incarceration of physicians, what was the process? How did this happen? This all led to us filing Freedom of Information requests and Freedom of Information Act requests, to Health and Human Services, Office of Inspector General, Drug Enforcement Agency, to just ask our government, hey, you guys are doing this. You guys came up with all these policies and plans. What exactly are you doing? How are you doing this? And, the response was very interesting, and I could go over that, and I'm planning on doing that right now. I'm going to share some screens here, basically, I'm going to show some slides, but basically, the prescription drug monitoring program was founded, in 2010 from Brandeis University, and the Bureau of Justice Assistance. They came up with this prescription drug monitoring program, with Brandeis University, and they implemented it with the National Association of Boards of Pharmacy to connect all the information of what drugs are being prescribed to everyday Americans. So the privacy of Americans have been eviscerated in terms of what medications they're getting. And they look and examine, how is the doctor prescribing to each patient? And, we were able to explain from, our research at Doctors of Courage and other organizations, how these systems were created by the United States government to look at, what are drugs of concern? Like, who decided what drugs are of concern? Who decided, what are patient alerts? Who decided, what clinical steps are raised in a report? And we first started looking at the prescription drug monitoring program, and we discovered a whole bunch of information. We have these slide decks. We even looked and we found the patent of how the algorithms that are used by the government and the National Boards of Pharmacy to determine whether a physician is acting criminal. Now, and then we found out that QLarent, or Health Integrity, was the nation's leading expert in fraud, waste, and abuse, and how they worked with the United States government to, basically go through these large-scale operations. I mean, the operation names are Operation Pill Mill Nation 1, Operation Pill Mill Nation 2, Operation Wasted Days, Operation Snake Oil, Operation, there's all these mass operations where they go out every year and arrest hundreds of physicians. And
that's the goal, just to find another physician to attack.
Correct.
Because that's their job and that's how they earn their money.
Correct. And they're different toolkits. And, we analyzed this, and we looked at what the government's doing, and they're doing something called targeted data analysis. And they
stay on this page for a minute. Don't flip off. I have some questions or
Sure.
Point out some things for people. Go ahead, though.
Sure. So, here, and we have these, we got this from the government, and hopefully we'll put this up on Doctors of Courage page, and I'll give you these documents, and people can download them after looking at them. But basically, this QLarent uses data analysts, and they say that we can identify the most likely drug-seeking patients. You can see here with the big arrow, and it's like a pre-crime process. It's like the Minority Report, that movie that was made with Tom Cruise, where they can predict who is going to be a criminal, and that really goes to the essence of free will. Are they saying they can predict who's going to be a criminal, that they have no free will, that everything is predestined? Because everything's predestined, what's the point of punishing someone? They had no control in the matter anyway. So these kind of questions are extremely deeply philosophical. And they come in, they invade philosophy, they invade religion, they invade, these are like godlike programs, and they're frankly very offensive. Like we talked about the Holy Trinity Project.
And yet the data that they have is basically totally interpreted wrong and skewed wrong, and everything about it is statistically wrong, right?
Yeah, I mean, based on we've asked them, we've asked the United States government through Freedom of Information, give us the validity and reliability testing of these computer programs that you're using. I mean, we do that for radar guns, for breath analyzers. There's got to be some scientific basis and reliability and validity testing to what they're doing.
Flip back to that previous page again.
Sure.
But for patients that are watching this, if you see here on what the targeted things that they look for to target a doctor, the number of controlled C2 prescriptions, pill counts, the distance a patient drives. But they're using that also against patients, because what they have now to identify a patient that's aberrant is called a NARC score, which was created, which actually Neil brought this to our attention. We appreciate that for Neil. But the NARC score, every patient gets a NARC score based on how many doctors they see. Now, as doctors are being knocked out of the market, or a doctor refuses to see a patient anymore, or they start tapering a patient off and the patient has to find another doctor, that raises their NARC score. So as the NARCs, and if now that there's limited, every year to try to control the booming, quote unquote, addiction rate, which is actually government caused, not helped by the government. They are limiting how many opioids are available. And so the pharmacies will run out before the month is out, before they get their next order in, and the patient goes in for their prescription, and the pharmacy will say, well, sorry, we're out of that medicine. So they have to go to another pharmacy. And in doing so, their NARC score goes up. So all of this stuff is just government created, and it's totally ridiculous.
Oh yeah, okay. We're going to go through the NARC score a little bit in the future, but here you can see tremendous, they're mining for trends and targets. They're coordinating for conviction. I mean, now they're working with the prosecutor, so the prosecutor gets a win. I mean, the Ruan case is described in this Q-Layer case study. They go over the Ruan case, and this is the Ruan case that came out in the Supreme Court. So, and they're talking about how this data team's partner, Q-Layer, actually got Dr. Ruan and imprisoned him. So this is all, and this is actually from Dr. Ruan's testimony. This is from the case of Dr. Ruan, this gentleman here, Kevin McCash. He's a physicist. He testified against Dr. Couch and Dr. Ruan about how their algorithm determined that Dr. Ruan was a pill mill doctor and was a criminal. And, they're being used in strike force operations all throughout the country, as we talked about before. This is some really nice view of our data, but this is, if we looked at where the strike force is attacking physicians, you can see here by state, it's in the largest states of the country, you're high risk. We've broken it down into different systems, and now we're talking about the NARC score and the NARC care. And the NARC score started in January 2011, and that's right around the time you were attacked, right, Dr. Shi?
Yeah, well, they came into my office the second time, June of 2010.
Okay, June 2000.
But I didn't have my trial until 2013.
Okay, so they were probably using, this NARCS program and these algorithms to determine, how to classify different people. And here we can see how these are the factors that they were using and the scores that they're using and how they calculate different scores and how they actually calculate. And this is kind of like a voodoo science. It's a junk science, like bite marks, and carpet fibers that were found to be fake, sciences. And, they have not been able to prove anything, and they have different cases. And we have a lot of this data from the from that we've collected over a past number of years. But basically, they're looking at number of providers, number of dispensing pharmacies, the amount of drug you receive, whether there's any overlap. Even though there are totally perfectly good reasons for this to occur. And this is how they actually calculate all these things. They're not only looking at narcotics, this LME is they're looking at lorazepam milliequivalents. So it's not just morphine milliequivalents. They're looking at benzodiazepine milliequivalents. This is just a junk science, never been proven, never been validated, never been proven for reliability. They actually combine all these things by measuring averages, okay, raw values over a period of time, and they make a score. And you can see here, they make a narcotic score. And if you look at it, they take a weighted average. If you look over here, a sum divided by 8, they come up with a score. And then the active number of narcotic prescriptions, and they make a narcotic score. They take that number 2 and add it.
Put it on the end of the 63.
Yeah, I mean, where have you ever learned?
It makes lots of sense.
It makes and how stupid are our judicial system, the judges and the lawyers and whatever. Nobody's even looking at all this stuff, the MME, LME. They're not looking at this.
No, but
the
jurors,
rubber stamping
the jurors just soak it up.
Yeah, they soak it up. If we throw some fancy math at these people with these red flags, and we'll make these narcotic scores and these 9 versus 600, we'll just throw them in prison. And
right.
and it's just a total scam. In my opinion, I've reached out to Apris Health and said, hey, I think this thing is a total scam. This is my research. Here. I showed it to them. Prove me wrong. Give me the data. Give me your raw data. Let's have a conversation. I have saved every email, and they don't want to talk to me. They refuse to talk to me. They don't want to give me any data, which is really improper. Because if they studies
in the scientific world, that is very improper.
It's very improper, and for them not to share data, and because they're using it now with patients, and I think it's going to become a huge debacle over time. It's going to be seen as a really bad part of human history, kind of like the Tuskegee experiment, kind of like putting Japanese in internment camps, or taking away the land from the Native Americans and putting them on a reservation. It's going to be a really bad part of our history with these huge errors that have been.
Now that they're also targeting pharmacists, and pharmacists are getting targeted by simply prescribing to someone that is considered to be an addict. So a pharmacist checks everybody's NARC score. And if their NARC score is where, I'm uncomfortable giving you this medication, then they're denying patients their medication, which they deserve, which then makes them have to go to another pharmacy, which raises their NARC score. I mean, it's all just total hype and like you say, just magic fingers, just moving things around. It's junk science, exactly.
I mean, Carl Sagan called it the demon haunted world. It's a dragon. Well, show us a dragon. Well, I can't show you the dragon. The magic dragon tells you if you're good or bad. Well, we looked at this, and they have huge internal errors. I mean, as the MME goes up or their scores go up, they go from error rate of 56% to 60% to 125%. And even if we look at their confidence intervals, you could have a score of 900 to 990, and that could be the same as a score of 500. So you have an order of, you could have a score of 500 or a score of 900, and it's the exact same thing, because the confidence interval at 48 exists at multiple different areas. It's so bad. It's such a bad system.
But it puts people in prison.
Yeah, it puts people in prison. I mean, even there's studies between.
Well, the problem with this, I'm sorry, Neil. The problem with this is most of the doctors who go to court, they have no income because the government has confiscated everything they own. or they've had to wait 3 to 4 years to go to prison without a job, so they again have no income. So they go into court with a public defender, which I personally use public pretenders. And they, of course, aren't going to know any of this information. They don't even know how to present it. So if when the prosecution, who's been trained over years, and their work is just cookie cutter, you do this, you present that, you put this person on the stage, you get what's his name, Timothy Munsing, to be your expert witness, and they just do the same thing repeatedly over and over and over. And yet all these doctors who have public pretenders whose basic job is to get the doctor to commit a plea, okay, to then go to court, and they're not prepared. It's no wonder we're all going to prison.
Absolutely. It's so bad. And we now have collected all this information, and it's just too overwhelming sometimes for, like you said, for these lawyers. There are very few attorneys in the country that actually understand what's going on. The judges, they're dealing with all sorts of issues, rapes and murders and healthcare, white collar crime. It's just, they have so many issues, civil cases, hundreds of different cases.
They make money, and they make money when they put these doctors in prison, Neil. The courts make money off of this.
Well,
there's all collusion there. There's all collusion there. I'm sorry, what'd you say?
I mean, their job is to, fix society through, punishing crime. But the problem is who's deciding what's criminal?
Yeah.
And that's what, I want to talk a little bit about that, because you and I, we learned about this. We filed Freedom of Information Act requests. We found out that they're using data-driven approaches to responding to the opiate epidemic. I mean, these are from the government themselves. These are, playbooks from the governments themselves, and they're basically saying these are the ways that they use. These are their playbooks. These are the government's playbooks on how do you go after a physician? How do you prove that they're wrong? How do you undermine a physician's defenses? How do you undermine their attorney's defense so you can obtain a conviction? I mean, it's disgusting stuff.
Convict at all costs. Yeah, that's what our justice system is now. Convict at all costs. And with immunity, they can do anything they want, including illegal acts, and there is no repercussion.
Correct. I mean, here's strategies for investigators and prosecutors and prescription drug diversion, and they're talking about different ways of attacking a physician. And a lot of this really got started with Jeffrey Sessions. And I'm going to show you some of his documents too, where he, came out and said, we're going to create targeting packages here and attack physicians, for, committing crimes and whatnot. So, I'm going to bring some of those documents up, which I think are very critical, very important for people to see. But Jeffrey Sessions, he made remarks to the DEA, Drug Enforcement Agency, saying we're going to use. This is his remarks on how to fight the opiate crisis, and if we scroll down here and we look at what he's trying to say, he says we're going to use something called data analytics. See right here, let me see if I can zoom in so that everyone can see this. But here he goes, for example, in August, I announced a new data analytics program, the Opiate Fraud and Abuse Detection Unit. I created this unit to focus specifically on opiate-related healthcare fraud. It uses data to identify and prosecute individuals that are contributing to this opiate epidemic. I can tell us important information about prescription opioids, like who is prescribing the most drugs, who is prescribing the most drugs, and whose patients are dying of overdoses. Numbers don't lie, even the fraudsters do. And now the fraudsters can't hide. And then he goes on to say, DA will aggregate the numbers to find patterns, trends, statistical outliers, and put them into targeting packages. So, and now this gentleman here, Tate Chambers of the Department of Justice, he explains, okay, this is how we actually do it. This is what we're going to do. This is how we're going to arrest hundreds and hundreds of doctors around the country, thousands of doctors, throw them in prison using these data analytics programs that haven't been tested. We're never, there's no validity testing nor reliability testing. And we're going to go after physicians and take all their assets and, fund this program by the stealing of their assets. And it's frankly, I've never seen anything like this or heard of anything like this. It's frankly crazy. And
the whole idea of going after opioids is just based on 100-year-old minority platform to disenfranchise blacks following the Civil War and to disenfranchise the Orientals that were coming in and bringing the opium when they were laying down the railroad. This is 100-year attack on drugs to simply disenfranchise people and to keep our country, quote, lily white, if you want to, phrase it. And yet we're still doing it. And now the government is actually trying to, worsen it and quoting an opioid epidemic when there is no such thing. And they just chose opioids again because that was, what they came up with after that attack on the DEA that the Congress had in 1998, that they chose opioids because doctors were easy targets. So all of this is government created, Neil. And how do we get that across to people? That what we need to do is completely get off the Controlled Substance Act altogether, legalize all drugs. We'll take care of the border issue. People don't have to escape cartels in Honduras because they're not selling the pills enough or whatever. And people would stop dying. There's just so many reasons to just basically do away with the Controlled Substance Act. We've got to get Americans to understand that. But I didn't want to interrupt from your explanation here, but we do time-wise need to consider.
Okay, yeah, just a few more minutes. I wanted to go through it. I agree with you that there's a solution. The solution is, obviously there's a vested interest. You and I filed Freedom of Information Act requests, and we got released information from Health and Human Services. This is our FOIA request that we got from the government, and they released documents about the Healthcare Fraud Prevention Partnership. And we learned in the Healthcare Fraud Prevention Partnership, which is, a public-private partnership between federal law enforcement, private payers, state Medicaid providers, and whatnot. But the federal government has combined with with insurance companies. Mm-hmm. And the insurance companies, they decide what's crime. Predominantly Blue Cross Blue Shield is they call them the champion partners. But
and I don't understand how we as Americans are allowing tax dollars to be benefiting the coffers of private insurance companies. How we are in cahoots with the insurance companies and the Department of Justice so that our tax dollars are being spent to attack doctors based on Blue Cross Blue Shield's complaints. This doesn't make sense at all.
Well, what's crazy is Blue Cross Blue Shield partners with certain doctors and certain hospitals, and they determine who to go after, who to criminalize and go after and knock out. So they're basically knocking out their business competitors who they don't like,
right?
Sanctioned by the government. The government's going along with it. And whoever Blue Cross says, okay, go after this guy. He's committing healthcare fraud. Look at our data analytics. We're paying him a lot of money. Well, they don't do that to Mayo Clinic. They don't do so. They have whoever they like is fine. Whoever they don't like, and whatever way they don't like to practice, get rid of them. And we talked about that in your interview and other interviews. But basically, that's what has happened. We have the proof that the Healthcare Fraud Preventive Partnership using this junk science data analytics. They decide which doctors to go after, never been proven. And now you have a situation where you can't get an Elon Musk. You can't get a Steve Jobs. You get a doctor who's independent thinking, or starts becoming rich or whatnot, or starts doing things that are different. Well, Blue Cross Blue Shield will, use their data analytic program and say, we paid this guy $5 million. This guy's a criminal. Go after him. That doctor might be brilliant. That doctor might be the next Michael Jordan. It's okay for Michael Jordan to take a sphere and put it in another sphere. Basketball player, let him be a billionaire. But this Dr. Ruan, he's a criminal. He's a drug dealer. Yeah, he was the smartest doctor in the United States. Yeah, he was the world, he was the world record holder, Guinness World Book of Records, most educated physician in the world. Mm-hmm. He made $5 million in 5 years. Let's put him in prison. But Michael Jordan, who's a billionaire, or, right. That's okay. He can be an athlete. That's okay. But, let's make this guy a drug dealer. Let's put him in prison. And now you got all Blue Cross Blue Shield throwing Dr. Leslie Pompey into prison, and all these other, the list goes on and on. We've had so many doctors come to us saying, what's going on with this Blue Cross Blue Shield? The Blue Cross Blue Shield complains about me and I end up in prison. What is this? They don't even pay my claims. If I complain that they don't pay my claims, they'll put me in prison. Mm-hmm. That's what Dr. Says. It's become so ridiculous, and we have to let the public know that this is going on, so they put a stop to it.
I just wish at some point people would realize that things would be a whole lot cheaper if we would just went back to the cash and carry, see the doctor, pay the doctor, and give up the insurance companies. If you just look at the buildings that these insurance companies, those buildings cost billions of dollars, and those billions of dollars is where people are paying into the system that they just paid the doctor I just charge my doctors $35 a visit. What is a visit now? The primary visit now for a doctor is probably $350 to get to see a primary care physician.
All the compliance you have to go through, because the insurance, you have to submit the bill to the insurance company. They reject 50% of the bills. They say you didn't do this right, you didn't quote this right, you didn't do. That's not doctoring. Oh, you didn't send us your medical records. You didn't do the medical records the way we like. Do a prior authorization. So and they got to get paid for the work they do, right? They got to get paid for their advertising. How many doctors you see advertising?
Yeah.
I see Blue Cross Blue Shield advertising.
Well, a doctor really can't. I don't think a doctor can advertise.
They can advertise. You got all these where I live. You got all these billboards with plastic surgeons, but you don't. But
you can't say you're better than some other doctor. There's some ethical rules there or something like that, right? Or cheaper or whatever. Yeah. Well. Is there anything that you want to say then to end this particular session, Neil? I know we left a lot of things that we can cover in another session, but I think this is probably long enough for people's attention span.
Yeah,
so
anything you want to say? Talk at some other time, and thank you for giving me the opportunity to actually finally go over some of the data we've collected, and hopefully we can share details with that data, or bring different have a roundtable with different physicians to actually go deeper into the data. This was just a forest from the trees, an overview of what we've collected over time, which I think is important for physicians to be aware of, and the general public as well.
Right. Okay. And so I'll just end this particular show then with sharing my screen. That I do this with all interviews, and that my goal is to basically do away with the Controlled Substance Act, no more drug war, and that we need all the people participating, doctors attacked. We need patients that have been, taken off their medicines. We need communication to the government, and we must end these attacks on good, compassionate doctors like myself, doctors like Dr. Anand, and people can do that by joining us. So we do appreciate you coming and telling us what you've learned, Neil. And if nothing else, I always look for the rose in the thorn bush, and that is that you were attacked, and yes, your life has been destroyed. But hopefully, with the work that you've done, we will basically stop these attacks on so many more doctors, and you will literally save lives. So I thank you for your dedication, and I thank you for your work, and look forward to you being back in practice in less than a year.
Okay. Thank you so much.
Okay.
Bye.
Bye-bye.